patients with high-risk myeloma certainly do benefit from all of the standard myeloma drugs that we use for other myeloma patients. They benefit from the use of proteasome inhibitors, they benefit from the use of IMiDs, they can benefit from the use of transplant. Having said that, we know that these patients, or at least some of the patients in the high-risk group, are going to have a shorter response than patients with standard risk genetics. And we have attempted to address that problem in the myeloma community by trying to intensify treatment for these patients, or by recognizing their genetic subtype and trying to address that with specific therapies. So patients with 414 myeloma, the translocation of chromosomes 4 and 14, we tend to try and offer more proteasome inhibitor upfront, early on, and additional consolidation or maintenance with proteasome inhibitors. For all high-risk patients, as these patients can respond to proteasome inhibitors and IMiDs, we try and look for a combination of both drugs early on if possible. So a combination of proteasome inhibitor and IMiD. We try and give the patient the best shot at getting a good remission from their myeloma through the use of our best drugs up front. It's also possible that these patients may benefit from the newer agents such as daratumumab, which works by a different mechanism and really doesn't require the same internal wiring of the cell to respond to treatment. And I think that patients with high-risk genetics may benefit from clinical trials. Patients with high-risk myeloma may also benefit from tandem stem cell transplant, so that patients with standard risk genetics would typically only offer one transplant, one dose of high-dose chemotherapy and one stem cell transplant up front following their initial induction therapy. And then we consider offering them another one at a later time point should their myeloma come back and they had a good response to the first transplant. However, patients with high-risk myeloma may never get that long-term response after a single transplant. And so we do, at some centers, offer them tandem transplant, meaning that they get 2 stem cell transplants separated by 2 or 3 months. And the benefit of this is that if their myeloma hadn't gone into a good remission after the first transplant but responded somewhat, the second transplant may push them into a deeper remission and they may have a more durable response at that point, often with maintenance therapy. Patients with high-risk myeloma may also benefit from clinical trials. There's a number of good agents coming through for myeloma, the BCMA-targeted agents, the BiTEs, the antibody-drug conjugates, the CAR T cells. These really work in radical new ways to treat myeloma. They aren't so dependent on the myeloma cell killing itself as a result of treatment. They bring in the immune cells to do this as an alternative mechanism. And so patients with high-risk myeloma, I think, do benefit, particularly from going on to clinical trials.